Good afternoon, everyone. So I'll be presenting an interesting case. The first one is a 45-year-old male patient presented with a history of acute pain and swelling of small joints of hand, wrist, elbow, knee, ankle, and he also had pain in the heel, lateral and medial epicondyle, and foot since 15 days. And the symptoms were same throughout the day, and it was associated with fever. And he also gave a history of early morning stiffness for about 1 hour. He also complained of sleep disturbance and headache. There was no history of back pain, weakness, skin lesions, or ocular symptoms or abdominal pain. There was nothing significant past history. In personal history, he used to smoke 2 packs of cigarettes per day, and he had stopped alcohol consumption since 1 year. Past medication, he was taking Vislon 10 mg BD and NSAIDs from the past 15 days. And these were the blood tests done before coming over here. And on examination, he was found to be afebrile. BP was 160 by 100. And also he had told that he had a recent onset hypertension from the past 2 months. Pulse was 87 and respiratory rate was 20. And otherwise there was nothing significant on the examination. And when he came here, we did the second round of investigations, and you can find that the things which are marked in red are little abnormal. So there was elevated ESR and CRP and neutrophils were high. And SGOT and SGPT was high, and in the urine showed 3+ proteins. And also hepatitis B was positive, and hepatitis BE antigen was negative. So what can be the diagnosis at this point? So this is only for the past 15 days.
Go ahead.
Go ahead. Okay. Acute, I don't think so.
Serum, that's one possibility, but you can keep that. Serum sickness like syndrome with hepatitis B. What else? There is something accelerated blood pressure is shooting high. What any clues for that?
Proteinuria from the past 2 months, the blood pressure is high.
Yeah, you can get in serum sickness. You can get a nephritis-like presentation, polyarthritis, fever, and those things. That can be there. Pardon? Yes, polyarthritis nodosa is another possibilities. The other possibility
ANA was negative, sir.
Yes, but ANA reported negative.
So the final diagnosis was polyarthritis nodosa only, based on the ACR 1990 criteria. So according to this, the 3 things were positive. That is, one was they had diffuse myalgia or weakness of the muscles, and he also had a diastolic BP which was more than 90, and also there was presence of hepatitis B. So the reported sensitivity of this is 82.2% and a reported specificity of 86.6% for the classification of PAN compared with other vasculitis. So in this patient, the lab features in favor of PAN was elevated ESR, CRP, leukocytosis, hepatitis B surface antigen, elevated creatinine level, and mild proteinuria, and also liver enzymes were altered. So was admitted and treated with solumedrol and discharged with gabapentin, methylprednisolone, azathioprine, amlodipine, and tramadol. He came back after 20 days with generalized weakness, fever, swelling of both foot, hyperpigmented firm subcutaneous nodules all over the body, nausea, vomiting, and loss of appetite. Rashes was associated with itching in lower limbs and buttocks. The BP had normalized, pulse was 98, and there was bilateral pedal edema. So this was the skin lesions which he had. And these were the next set of investigations which were done. And SGOT, SGPT were normalizing, and creatinine had become normal. So urine culture and sensitivity, there was no growth, and QBC malaria parasite was negative. And this was a skin biopsy slide, and I request Dr. Manjunath to come and explain about this slide. Dr. Manjunath is a professor in Dr. Ambedkar Medical College, and also HOD also. And HOD. I was. Okay, sir.
The skin biopsy which was sent to us, so the skin biopsy which was sent to us, and it was a whole thickness skin biopsy, including the subcutaneous tissue as well. So most of these vasculitis, one need to have a subcutaneous tissue as well when we have this biopsy done. So the first section shows that there is a skin which is apparently having a mild hyperkeratosis without much evidence of any other change over in the epidermis. Deep in the dermis, in the subcutaneous, we have seen the next slide shows there is a vasculitis of a medium-sized blood vessel. So it's a medium-sized arterial disease. So the next one where we see that there is fibrinoid necrosis of the vessel wall, and there is also neutrophilic infiltration along with lymphocytes which are there, and the another blood vessel which is possibly a little older one, which has gone for a total sclerosis and recanalization process was there. So all these put together, we gave an impression that it could be a polyarthritis nodosa that was associated, where it could be HBsAg positivity, which would have initiated an antigen antibody reaction over the vessel wall and caused polyarthritis there. So this was our histopathological opinion about the polyarthritis that we saw in the histopathology.
Thank you.
Thank you.
No, actually, I think now the biopsy makes it more clear, the diagnosis.
So, at present, at this time, there were 5 points which were in favor of PAN. That is the skin lesion, myalgia. This was the case, and okay. So unfortunately, we lost the patient. So there was a 5-point score, which tells that the probability of what is the prognosis. So after 20 days, after the patient was discharged, he went back, he was fine, and suddenly one day he fell down, and that was the last. That was what the relatives came and told.
It was a coronary vasculitis. That's
coronary vasculitis might be the...
Now, it's a typical polyarthritis nodosa. Actually, if you can see that, probably suspicion helps you to pick up the diagnosis much earlier. In a patient who have multisystem disease with hepatitis B positive, even without a nodular biopsy, one can reasonably think and consider the diagnosis. But of course, diagnosis threw open in his next visit, but it was a worst thing threw open after 15 to 20 days in spite of the treatment. The biggest challenge in most of the autoimmune disease is this. Once the disease process of autoimmune disease starts rolling, it takes time to get it under control. But much before getting it under control, we sometimes lose the patient. This is what happens in is quite a good frequency of autoimmune disease. Lupus, vasculitis, even for that matter in Guillain-Barré syndrome, in some of the myasthenia crises, etc. Once the autoimmune process starts rolling in, till it reaches a point, it doesn't roll back. With the plasmapheresis, and those are the things which can help us in containing those kind of autoimmune rolling disease process. But it's very difficult to take a clinical guess when and where to use it. Any comment?
Does it also lead to a lesson that we have to investigate for the cardiac health status in all these arthritis patients? ECG and level test, because it is positive because of the coronary vessel involvement. If we had done the coronary workup earlier,
Could we have saved it? He will comment.
Morning, probably I had emphasized that all these patients with systemic autoimmune disorders, because they are generalized systemic immunity going on, generalized inflammation going on. It's equivalent to what we call as diabetes, atherosclerosis equivalent. And all the autoimmune diseases can also be considered like diabetes as equivalent for coronary vascular disorders. But here the situation was different. Person was ill because of some other disorder, so he could not be subjected to all those investigations, and probably TMT was not possible. Probably echo would have picked up something. But what I feel is, if he had been treated with cyclophosphamide along with methylprednisolone, that could have probably, and as Chandrasekhar said, maybe few cycles of plasmapheresis, because the suspicion is key to survival sometimes.
So, but because he had hepatitis, we don't go for the
We were
cyclophosphamide.
little worried about cyclophosphamide and hepatitis B. I think we could have gone ahead. Actually, we retrospectively, we also thought that cyclophosphamide could have saved him, but it's a tough question to take.
In this particular situation, IVIG would have been a better option.
We started him on Solumedrol and MMF.
Now, if you could see that, actually some of the biochemical parameters started improving. Creatinine, which was around 1.8, stepped down to 0.8 in the subsequent visit. Liver enzymes started tapering, coming back to normal. Clinically, he was a little bit well when we sent him home, but the coronary vasculitis was unexpected.
Okay.
This is a case which has been given as the case for the day. I think I could see around 30 of you have attempted. He will unreveal the diagnosis quickly in 3 minutes.
53-year-old gentleman with multiple bullous, fresh and healed erythematous lesions since 3 years. And he has started as papillosquamous erythematous itching and rashes from the past 2 months. And it involved the lips, face, scalp, upper limb and lower limb and entire body. By 2 months, the entire body was involved. And there was itching and painful oral ulcers, bullae formation. Some bullae were burst and seen as erythematous abrasions. Healed and non-healed lesions were there. Commonly, the lesions got worsened during winter. The glands and eye were spared. There was no history of joint pains, no backache or no weakness. And these were the skin lesions with which the patient came to us. And the investigations, as it's been written here, and also with it's also been printed in the paper which we have given.
This one is the closest.
And the next. So here almost the ANA was also negative. Next. And rheumatoid factor, everything was negative. And these were the tests done outside. For the histopathological examination was done and the skin biopsy showed this many features, through which it was thought that it is the bullous lesion, and he was treated for that. Okay. So the main thing here, important thing was to recognize that the eosinophils were very high. So that was the clue for this thing, and that was missed by 2 of the dermatologists. The first dermatologist had treated it as psoriasis for about 3 years and there was no improvement. Then he went to the other dermatologist and again he was given on steroids and still there was no improvement. The things which were to be noted was the eosinophils were high and it was only during the winter season and not throughout the year. Mite and parthenium. So once we started him on antihistamines and the steroids, it helped him and he was better. Actually the photographs, if it is there, we can show after the treatment what was the improvement we could have shown. But when it comes, we'll show that.
Actually, this case is the one which we had given it for the case of the day. I could see around 25 of them have attempted. And of course, the only one right closest answer has come. It's been written as atopic dermatitis. I think absolute eosinophil count was the things which was asked, but actually more than absolute eosinophil count, because already eosinophil percentage has been given as 43% in the case history. So the best would have been to go for a serum IgE and if need be a skin biopsy. So one of the important thing is that when we are trying to...
Skin biopsy was done.
Pardon?
Skin biopsy
Skin biopsy done, it also showed...
yeah, and they told it is a bullous.
No, actually the outside skin biopsy interpretation was done as bullous. The biopsy, we didn't do the biopsy because we were straightforward, it was an eczema and we didn't want to go for a biopsy because we had no confusion about the diagnostic possibility. The whole case was misled and misdiagnosed because the pathologist from other place was given a diagnosis as bullous pemphigus. So that's where the treatment line was on a different set of points. The clue is here is actually what the case we wanted to bring forward is that there will be subtle clues sometime in an as simple test like in a peripheral smear. Peripheral smear, the eosinophil is starkly very high. Here it is around 63%. 63% out of 15,000. I mean, that should put us to think that probably the whole process is either an eosinophilic based disease or an allergy based disease. Serum IG would have differentiated whether it's an allergic disease or an eosinophilic dependent disease. So you have an allergic eosinophilic dermatitis and those kind of set of diseases. Other possibilities, an allergic dermatitis like eczema, etc. So the one which differentiates is IgE. If serum IgE is very high, it suggests to a possibility of eczema. So then next best test to do is what we call as immune cap or a pinprick test or other methodology in which you can figure out what is the specific allergen to which he is allergic. Then you can, if it is avoidable, avoid that. Not avoidable, use slit therapy or other immunotherapies which can definitely bring down a significant improvement in this particular case. The patients of these kind of eczemas can be helped by simple immunotherapies which really makes a big difference for this set of patients.
So after the slit therapy, the skin lesions were like this. It has improved. In fact, the last visit when he came, it was much better, but we didn't take the photograph in his last visit.
Last visit, almost skin has become quite close to normal actually.
Thank you.
Any question on this case or?